Our next speaker is Dr. Shelby Dames. She'll be talking on rheumatology. She works at McKay Rheumatology. She received her bachelor's degree from the University of Colorado at Boulder, the medical degree from the University of Iowa, residency in internal medicine and rheumatology fellowship at the University of Utah. She's done clinical research and published in the New England Journal of Medicine, has spent time in the South Pacific collecting data for the World Health Organization on TB, and she did an exchange program in Kenya. Her most recent achievement is becoming a first-time mom to her baby girl, Alexandra, born November 2011. So let's welcome Dr. Dames.
Thank you very much for having me here today. So the title of my talk today is What the Non-Rheumatologist Should Know About Biologics. So I first need to disclose the fact that I've been a consultant or speaker for several pharmaceutical companies, including Abbott, Amgen, Genentech, Pfizer, Takeda, and Wyeth. Today we're going to go over some background information and briefly give an overview of several commonly used biologic medications in rheumatology. We're going to discuss the risk of infection, the use in the perioperative period, the use of immunizations with biologics, malignancy risk when using TNF inhibitors, and also consider biologic use in the setting of pregnancy. When I was asked to give this presentation, I was told that a lot of physicians in the community really feel uneasy when they hear that a patient is on a biologic medication. And so I hope to increase your familiarity with these types of medications. And I want you to understand the potential serious adverse effects associated with these medicines and become aware of some of the common practices when we're considering the use in the setting of infection and malignancy in the perioperative period and pregnancy. But we also need to understand that the decision to use a biologic therapy must be an individual one based upon the specific clinical features and risk profile for a specific patient. As a disclaimer, I'm going to tell you what this talk is not going to cover. So this is not going to cover detailed information regarding biologic medication mechanism of action, because that's certainly a way to put everybody to sleep first thing in the morning. It's also not going to cover all potential risks for biologics in the interest of time, and I'm not going to be comparing efficacy of these medications, and we're not going to be discussing any non-rheumatology biologic medications. So the background of biologics. Biologics are really treatments that are going to use the body's natural abilities to stimulate or restore the ability of the immune system to fight infection or disease. Basically, it's a targeted way of using the immune system. So an example of a biologic would be a monoclonal antibody that targets TNF alpha. This is a very specific part of the immune system, as opposed to a non-biologic medication like prednisone, which has a blanket effect on the immune system. So biologics have really represented treatment advances for a number of inflammatory conditions. And really, without biologics, I probably wouldn't be standing here before you today because I probably wouldn't be a rheumatologist. The field of rheumatology was dying about 15 years ago. All of the programs were starting to shut down. Nobody wanted to go into rheumatology because we didn't really have a whole lot to offer. We had conventional DMARDs like methotrexate, and we had prednisone and anti-inflammatories, but a lot of physicians argued, well, what primary care provider can't prescribe aspirin and ibuprofen? About 15 years ago, as they started to look at using TNF inhibitors, the whole world of rheumatology changed. It just blossomed. And I think this is a very exciting area because we have a lot of hot research in the area of rheumatology. And we're going to talk about some of the risks associated with these medicines, but we really need to remember that these medicines provide a huge amount of benefit for patients as well. Sometimes we focus so much on the risk that we forget why we're even taking these medicines to begin with. And I want to give you an example. A rheumatoid arthritis patient that has uncontrolled inflammation has a high risk of having joint dysfunction because of damage over time. They're likely to end up on disability. If they're untreated, they're likely going to have erosion seen in x-rays within 2 years. There's a very good chance that they could have an extra articular manifestation of their disease, like pericarditis. And the biggest thing is that their life expectancy is reduced. So the side effects of untreated or undertreated rheumatoid arthritis are huge. And so when we consider these scary side effects of a biologic, we need to take that into consideration, because the potential side effects of a biologic are nothing compared to the side effects of untreated rheumatoid arthritis. We're going to spend a lot of time talking about TNF inhibitors today. So there are 5 approved TNF inhibitors that are approved by the US FDA for treating rheumatoid arthritis, ankylosing spondylitis, inflammatory bowel disease, psoriasis, and psoriatic arthritis. And I've listed these in the order of approval dates. So you can see that etanercept was approved in 1998, and at the bottom, certolizumab was approved in May 2009. And I've listed to the side all of the different indications. You can see that there are some differences between medicines because not every medicine is approved for every indication. And although they're in the same class, there are some subtle differences in mechanism of action which may affect the efficacy and safety. And this may be why some of the medicines don't work for every disease. And I don't want to read through this entire slide because you probably aren't going to remember these subtle differences, but I just want you to take away the point that these are not all the same. One TNF inhibitor is not equal to another. That's why if somebody fails one medicine, there's a chance they could respond to another one. There are also differences in dosing and administration for the TNF inhibitors. So all of the TNF inhibitors are either administered subcutaneously or intravenously. And there are 4 that are administered subcutaneously: etanercept, adalimumab, golimumab, and certolizumab. And the dosing interval differs depending on the medication, anywhere from once a week to once a month. And this is a home self-injection, as opposed to infliximab, which is an intravenous infusion that's performed in the office. And the dose is different depending on weight. So we have a range between 3 milligrams per kilogram up to 10 milligrams per kilogram. They could receive an infusion every 4 weeks or every 8 weeks or everywhere in between. So this talk is focusing on TNF inhibitors today because this is the most commonly used rheumatologic biologic class. So most likely, if you have a patient that's on a biologic, they're probably on a TNF inhibitor, statistically speaking. And also, TNF inhibitors were approved before the other biologics, and so there's a lot more data in regards to safety than the other rheumatologic biologics to share. We're going to briefly talk about rituximab. This is another biologic. This is a B-cell therapy. It targets anti-CD20. And it's approved for treating rheumatoid arthritis, also ANCA-associated vasculitis, like Wagner's granulomatosis. It's also used for non-rheumatology conditions such as non-Hodgkin's lymphoma, chronic lymphocytic leukemia. And this is dosed as 2 infusions, 2 weeks apart every 6 months. They're quite long. They take about 5 to 6 hours. I'm also going to briefly mention abatacept, or Orencia. This is a co-stimulation modulator that inhibits T cells. It basically stops the interaction between B cells and T cells, and it's approved for treating rheumatoid arthritis. And it's also administered intravenously 30 minutes for an infusion every 4 weeks. And within the past year, the FDA has also approved a subcutaneous form of this medicine that's available as a home injection every week. Tocilizumab, or Actemra, is an interleukin-6 inhibitor, which is approved for treating rheumatoid arthritis. They have to have failed a TNF inhibitor first. And it's also an IV infusion that's given every 4 weeks for about an hour. So one thing you'll notice is that all the biologics I'm mentioning are either administered subcutaneously or intravenously. This is really a problem for some patients who really don't want to use subcutaneous or IV medicines. And I'm going to mention that the FDA advisory panel has recently suggested to the FDA that a JAK1 inhibitor, which would potentially be the first oral biologic for treating rheumatoid arthritis, be approved. So we could see this in the next few months to years. We don't know. But this would be a big change in the field of biologics. I'm also going to mention denosumab, or Prolia. This is not a rheumatoid arthritis biologic. This is actually a postmenopausal osteoporosis biologic, and it's a fully human monoclonal antibody to rank ligand, which inhibits osteoclast formation, function, and survival. And this is dosed as a 60 milligram injection subcutaneously in the office every 6 months. So going back to TNF inhibitors, I'm going to mention some of the adverse effects. Injection site reactions are by far the most common reaction, except with, of course, infliximab, which is not given subcutaneously. Injection site reactions are usually very mild and not a reason to stop the medicine. Sometimes they'll show up a few weeks after the medicine was started. Sometimes they'll show up right away, and they're usually like an itchy mosquito bite, sometimes larger, and sometimes the patient that has received multiple injections will have little polka dots everywhere where they've injected over the past few weeks. And it usually goes away. They can take Benadryl. They can go ahead and make sure the medicine is warmed up before they do the injection. They can use some hydrocortisone to help with the itching, but it's pretty self-limited. Infusion reactions can occur with any medicine that we infuse, including infliximab. Infections and potential malignancy risk are things we're going to be focusing on in just a minute. There's also cases of induction of autoimmunity, where patients can develop an MS type reaction, or also lupus, drug-induced lupus reaction, although this is quite uncommon. And heart failure exacerbations have also been reported with TNF inhibitors. When we discuss the risk of infection for patients that are on biologics, this is a very sticky issue. So traditionally, clinical trials exclude patients that are prone to infection. So we're not really studying the real rheumatology population. We also know from studies that patients with inflammatory arthritis, such as rheumatoid arthritis, are more prone to infection compared to the general population. And this is before they even get on any immunosuppressive medications. This makes sense because they have an autoimmune disease. Their immune system, which would normally be targeting infection, is sort of confused, and it's really targeting the patient. And so the immune system is really distracted and not really noticing the infections. And in some cases, physicians really believe it's the uncontrolled inflammation that leads to the increased infection risk. And in real-life practice, patients with the most active inflammation are the ones that we're going to be targeting for biologic therapy. So there are currently no consensus guidelines regarding how we should screen for infection before we start a TNF inhibitor. But if you talk to rheumatologists across the country, most are getting a PPD to screen for tuberculosis. They're screening for hepatitis B and C. And if there are risk factors present, they're screening for HIV. There is clearly an association between granulomatous infections and TNF inhibitors. So TNF-alpha is required for the maintenance of a granuloma structure. And so if you break that down, the risk for reactivation of tuberculosis or histoplasma or cryptococcus or candida is increased. Fortunately, those types of infections are rare, especially for screening in advance. So, do TNF inhibitors affect infection risk? Well, there is some data that suggests that there is no increased risk of infection associated with these medications. So if you look at the individual randomized clinical trials of the TNF inhibitors, they failed to demonstrate a consistent increase in treatment-related infections. But remember, they were also excluding patients that were prone to infection. There was also a retrospective cohort study of US patients that had rheumatoid arthritis, inflammatory bowel disease, psoriasis, psoriatic arthritis, and ankylosing spondylitis. And it showed no increase in the risk of hospitalization for infection in these patients that initiated a TNF inhibitor versus a non-biologic agent. And that was published in JAMA in 2011. There's also evidence for increased risk of infection associated with these medicines. There was a meta-analysis of randomized clinical trials for infliximab and adalimumab that included approximately 3,500 patients on TNF inhibitors and about 1,500 patients that were on placebo. The pooled odds ratio for serious infections for TNF inhibitor patients was 2.0. And 12 of the 126 serious infections were granulomatous, so not very many actually. If you excluded the granulomatous infections from the analysis, the odds ratio was 1.9. There was also a German registry study. It was an observational study that compared 512 patients on etanercept, 346 patients on infliximab, and 601 patients that were controls. And a control was a patient that had failed the therapy with a DMARD, and they were starting another non-biologic DMARD. The number of serious infections per 100 patient years for etanercept was 6.4, for infliximab was 6.2, and for conventional DMARDs was 2.3. If you look at a multivariate analysis of the German registry data and you adjusted for disease duration, the number of prior therapies, the number of involved joints, and disease activity, the relative risk of severe or moderately severe infection when compared to conventional DMARDs was 3.0 for infliximab and 2.3 for etanercept. There's also evidence for increased risk of infection when you look at a retrospective cohort study of veterans in the US with rheumatoid arthritis. This is a very interesting study that I want you to pay attention to because prednisone use and TNF inhibitor use was associated with hospitalization for infection, whereas DMARDs were not. Prednisone hazard ratio was 2.14 versus the TNF inhibitor hazard ratio of 1.2. So you can see that prednisone is a lot more associated with infection than TNF inhibitors. Therefore, one of our goals as a rheumatologist, if we can't get a patient off of prednisone, it may be worthwhile considering a biologic therapy to help them get off of prednisone because their risk of infection is a lot higher if they stay on prednisone than if they go on a biologic. So, when considering what to do in the setting of active infection, you have a patient that comes in to urgent care and they have influenza and they happen to be on etanercept for their rheumatoid arthritis. What do? Well, unfortunately, there are no clear guidelines that exist. So in the past, when TNF inhibitors were brand new, rheumatologists were very fearful that we were going to be causing a lot of infections with these medications. And our goal was really to hold the TNF inhibitor with any minor infection. It could be a hangnail, it could be the start of sniffles, we didn't know if it was the start of an infection or maybe seasonal allergies, but we would just tell the patient to hold the TNF inhibitor. The problem was that a lot of patients were not receiving their medication regularly enough to make a difference with their arthritis. Their arthritis was flaring all the time, and then we had to use prednisone to help control the inflammation. And if you remember that study we just discussed, the US veterans, we know that prednisone is more likely to cause infection than the TNF inhibitor. So current trends, when you talk to rheumatologists across the country, are really to continue the TNF inhibitor if it's a minor infection, such as an infection treated as an outpatient, maybe a cold, a urinary tract infection, or a minor sinus infection, because we know these patients are at higher risk for these to begin with. And we would hold the TNF inhibitor in the setting of a serious infection, for instance, an infection requiring IV antibiotics or hospitalization. The problem is it's really a judgment call. Who's to say whether infection is mild or severe? There are definitely cases where it's obviously mild and obviously severe, but there's a lot of gray in the middle. So basically, the decision whether or not to continue the TNF inhibitor should be made on a case-by-case basis. So the takeaway points when thinking about TNF inhibition and infection are that TNF inhibition clearly increases the risk for granulomatous infection, but these types of infections are actually very uncommon. We don't have a lot of tuberculosis in the United States. TNF inhibition likely does increase risk for overall infection. However, it's really impossible to determine what proportion of the risk is from the treatment versus the underlying risk from their disease. The decision to hold a TNF inhibitor in the setting of an active infection should be made on a case-by-case basis. And infection risk is higher with prednisone than with TNF inhibitors. What about use in the perioperative period? Again, no official guidelines exist. There is one study, a very small study, of 91 rheumatoid arthritis patients that were receiving an orthopedic surgery, and it showed that 7 of the 10 patients who suffered an orthopedic infection had received a TNF inhibitor at the time of their surgery, compared to only 28 of the 81 of the patients that did not develop infection. So based on this, a lot of rheumatologists started recommending that we hold a TNF inhibitor in the setting of a scheduled surgery. The major drawback of this study is that patients with the most active or severe disease are more likely to be prescribed TNF inhibitors, and there was no way to control for this in the study. So old practice trends were to really hold the biologic for as long as possible. But new practice trends for an elective surgery is to try and time the surgery when the next biologic dose is due. So if you have a patient that's on etanercept and they're receiving weekly injections, we try and time the surgery at the time that their next injection is due and hold that injection. or if they're on a Remicade or infliximab infusion and they're scheduled to receive their infusion in 8 weeks, that's when we try to time the surgery. The rationale is that if there are arthritis flares when we're holding their biologic, again, we're more likely to use steroids, and steroids are more likely to interfere with healing and increase infection risk than the biologic would. And although we're not really talking about methotrexate, I just want to make a side note that it is recommended to continue methotrexate in the perioperative period. I have a lot of surgeons that decide to hold this medicine, and all they're doing is causing the arthritis to flare. It takes about 3 months for the medicine to be fully out of the patient's system, so holding a dose is not likely to improve their outcome, as associated infection risk is actually very low with methotrexate. What about immunizations when patients are on biologics? Well, in the perfect world, patients should really be brought up to date before initiating biologics and get their vaccinations done, especially if they're going to think about rituximab, which is a B-cell inhibitor. And B-cells are important for making antibodies. And so a patient that has been on rituximab often cannot go ahead and generate an immune response to a vaccine. Patients need to wait at least 2 weeks after receiving the herpes zoster vaccine before initiating any biologic therapy. And they should not be receiving the Zostavax if they're currently on biologic therapy, because vaccines that contain live organisms are contraindicated. That would also include vaccinations such as the yellow fever vaccine for people who are wanting to travel abroad, and the flu mist vaccine. All patients that receive biologics should be receiving the pneumococcal vaccine. Switching gears, we're going to talk about malignancy and TNF inhibitors. And there really is a challenge when trying to establish malignancy risk for these patients. Patients treated with TNF inhibitors may have a predisposition to cancer based on their underlying disease. We know that rheumatoid arthritis patients have a higher risk of lymphoma and lung cancer compared to the general population. They also have a reduced risk of breast cancer and colorectal cancer, and we don't know why that is. Patients that are receiving a biologic medication are often on other medicines that could impact their cancer risk. For instance, a patient may be on prednisone or on methotrexate. And cancer patients are again excluded from clinical trials. The sickest patients that have the most inflammation are also the patients that we usually target for TNF inhibition. And so, again, is it the high inflammation level that increases malignancy risk, or is it the medicine that we're using to treat the high levels of inflammation? There is evidence for increased risk of malignancy associated with TNF inhibitors. The FDA has identified 48 cases between 1998 and 2008 of malignancy in patients on TNF inhibitors. Half had Hodgkin's and non-Hodgkin's lymphomas, and that included 10 cases of hepatosplenic T-cell lymphoma in patients with inflammatory bowel disease that had received 6-mercaptopurine or azathioprine. But other cancers were reported as well, such as leukemia and melanoma. And so warnings regarding TNF inhibitor use in children and adolescents were issued based on this analysis, and warnings regarding adult leukemia was issued based on this data. There was also a meta-analysis from 9 clinical trials involving about 3,500 patients that had received TNF inhibitors and 1,500 who had received placebo. This was published in JAMA in 2006. The pooled odds ratio for all malignancies among patients on TNF inhibitors was 3.3. Dose-related risk existed, so patients that received higher doses were more likely to develop a malignancy. And for patients receiving TNF inhibitors, the number needed to induce one additional malignancy of any type within a 6 to 12-month treatment period was 154. There's also evidence of no increased risk of malignancy associated with TNF inhibitors. There's a Swedish population-based registry study of RA patients published in Arthritis and Rheumatism in 2009 that showed that there was no overall elevation of malignancy risk during 25,693 person-year follow-up in 6,366 patients that had started on a TNF inhibitor compared to a biologic-naive RA cohort of 61,000 patients. The relative risk of cancer and incidence of cancer did not increase with time after starting the TNF inhibitor. The meta-analysis of malignancies and TNF inhibitors showed that skin cancer risk is elevated, but not risk for other cancers compared to patients receiving DMARDs. So the takeaway points when considering malignancy and TNF inhibitors, Rheumatoid arthritis patients have a higher risk of certain types of cancer like lymphoma and lung cancer compared to the general population. And we don't know if that risk is related to the disease because of the inflammation or because of the medicines that we're using to treat the disease. And I would also like to recommend consideration of an annual skin exam for every patient on a TNF inhibitor because of the increased risk for skin cancer. What about biologic use in pregnancy? So TNF inhibitors are classified as pregnancy class B, and so they probably are safe. There are registry studies ongoing looking at this issue. It's recommended for patients that are going to be on rituximab that they avoid pregnancy for at least a year because of the long duration of the medicine in the body system, and also because the medicine crosses the placental barrier. So this is an important discussion to have if you have a young woman with rheumatoid arthritis and you're going to consider rituximab. They have to commit to no babies. There's limited data regarding safety in pregnancy for rituximab, abatacept, and tocilizumab. And denosumab is only approved for postmenopausal osteoporosis, so this shouldn't even be coming up. So in summary, biologics are associated with potentially serious adverse effects. However, these risks must be considered in the context of the potential benefits associated with these medications. And I want to leave you with this. As a rheumatologist, I have become very accustomed to talking to patients about complicated medicines that have a lot of scary sounding side effects. And I have to be able to convince them to go on this very scary medicine. I bring up the fact, again, that untreated rheumatoid arthritis has a lot more side effects and potential risks than the risks associated with biologic therapy. And I will often give this example. Every day when we decide to get into a car, we are performing a risk-benefit analysis. Most of us decide to drive, even though we know that there's a risk for death, there's a risk we could have serious injury, and a very expensive car repair bill. And the reason that we do it is we feel that we have a lot of benefit from driving a car. We're going to get to where we want to go a whole lot faster. We're probably going to avoid the elements such as a rainy day. We're going to be able to carry a lot more things with us than we would be able to as a pedestrian or a bicyclist. And so we're performing that risk-benefit analysis every day. And I hope that example may help you discuss some difficult situations with patients as well. So thank you again for having me. Dr. Allen. So the question is whether or not we screen patients differently depending on their regional area where they have lived in the past. I wish I could say yes. We talk about it all the time, but again, there's no official guidelines. Often I'll ask patients if they've had a history of living in the Midwest or in Arizona, and I'll make note of it in the chart, and I will tell them that there is a potential risk for reactivation of granulomatous infection. But part of my screening before I start a TNF inhibitor is to get a PA and lateral chest x-ray, and if there's any signs of old granulomatous disease, we really have to make note of that and take that into consideration if they were to develop a febrile illness after starting on a biologic.
Dr. Dames, a question for you. How are you managing patients that come into the office that are on a sub-Q biologic that come in with an active zoster infection? Do you hold the shot for a period of time? Do you prophylax with an antiviral? And if you do, for how long? I've seen these patients occasionally with Crohn's that come into my clinic and want to know what you do with RA.
Yes, Dr. Gonzalez, that is a very difficult question. Again, no guidelines, but it's a judgment call. I probably would go ahead and hold the medication and give them time to recover from that infection, and I'd have a low threshold for antivirals in that setting. And if they're going to be holding the biologic for a few months, it might be a good time to do the Zostavax. Any other questions? Yes? Okay, so the question is about the duration of treatment for biologic therapy. An example would be a rheumatoid arthritis patient. Unfortunately, if you stop therapy for a rheumatoid arthritis patient, the disease comes back. So the hope of having somebody in remission when we're talking about a rheumatology patient is to have no signs of disease while they're on some sort of immunosuppressant therapy. It doesn't mean that that particular patient will stay on that same biologic. We're constantly reevaluating risk-benefit ratios. So if a patient has developed a problem where they're having recurrent infections or maybe malignancy, it may be in the favor of the patient to stop that medication. Or if they stop responding to the biologic, why even take the risks associated with that medicine? So you want to make sure that they're continuing to respond, and that's why it's worth taking those risks. And that's part of the reason we like to follow these patients closely. We're constantly reevaluating that risk-benefit ratio for that particular patient. The good news is that there's lots of different types of biologics coming out. And so if they stop responding to one medicine like a TNF inhibitor, maybe it's time to move on to B-cell therapy or interleukin-6 inhibitor therapy. And so, unfortunately, most RA patients are going to have to be on some sort of immunosuppressant medicine their entire life. There was also a question about what about the cost of these medicines? That is a very difficult question. At one point, there was going to be an expiration of the patent for etanercept, but they just extended the patent. So we were going to be looking at what we call follow-on biologics or generic biologic medications. This is a very difficult topic because part of the reason that these medicines are so expensive is that it was hard to develop these medicines. They're also very expensive to make. These are not natural compounds that are found. These are medicines that are developed in the lab. And some of the other countries, like in India, they are starting to make generic biologics, but part of the way that we save money is to not study the safety. Do we want to put a patient on a medicine that is having a very big effect on a part of the immune system that we haven't studied the safety of? We have to remember that generics are only 80% as effective as brand name medicines in a lot of situations. And so that's a very difficult topic. Unfortunately, a lot of these medicines are very expensive. They could range from thousands of dollars up to maybe even $30,000 a year out-of-pocket cost, which nobody can afford. There are a lot of patient assistance programs out there for patients that do not have insurance and that actually do have insurance as well. And so most of my patients that are on biologic therapy are not paying very large copays. It's usually less than $20 a month.
We'll just take this one last question. Oh, okay.
Here?
Oh, okay, I'm
if
sorry.
a patient with an acute abdomen, would you expect a decreased inflammatory response? So acute diverticulitis on a CT, would we see changes on a CT? We've seen patients in the ER on these medicines, and that's a question we keep wondering. Are we missing diverticulitis in these patients with left lower quadrant pain because they're not mounting an inflammatory response?
I don't know of any data looking at that question. And I don't think I really know the answer to that question, I have to say. We don't really know. Of course, if you inhibit TNF-alpha, you're reducing granuloma formation, and so it is possible that these patients may not present in the same way. But at the same time, I'd like to point out that if a patient is on prednisone, we're in the same boat. It's not unique to these biologic therapies. Thank you very much for having me today.